having two more faculties, Dr. Sheshadri, who is a consultant gastroenterologist, and Dr. Preeti, who is also a consultant gastroenterologist. We are planning to have two case scenarios. One is management of Barrett's esophagus, which was presented by Dr. Bhavin, our final year postgraduate. And the second is an interesting case of jaundice with its sequelae, which is presented by Dr. Vivek. I request Dr. Bhavin go ahead with the present his lecture on management of Barrett's esophagus. Over to Bhavin.
Very good evening to everyone. Myself, Dr. Bhavin Davra. I am a third year DNB registrar from Apollo Hospital, Chennai. At the outset, I would like to thank the faculty at Apollo Hospital and the NBE board for giving me this opportunity to present this on a national platform. So my topic for today is I'm going to present a seminar on management of Barrett's esophagus. Starting with a brief introduction. Just a minute, sir. The slides are not moving.
Click on the presentation once.
Yes, sir. So starting with a brief introduction to the topic, Barrett's esophagus is the condition in which an abnormal columnar epithelium, which has both gastric and intestinal features, and that is predisposed to develop malignancy, replaces the normal stratified squamous epithelium that normally lines the distal esophagus. It is a consequence of chronic GERD, which damages the esophageal squamous epithelium. This damaged squamous epithelium then heals through a metaplastic process in which the columnar cells replace the reflux damaged squamous cells. This metaplastic tissue has a tendency to develop dysplasia and then a carcinoma. So the degree of dysplasia remains the best predictor of progression of cancer. The risk of cancer progression in these patients is as follows. For the patients with no dysplasia, it is about 0.2 to 0.5% per year. For patients with low-grade dysplasia, it is about 0.7% per year. And for patients with high-grade dysplasia, it will be as high as 7% per year. Coming to the management proper now, we'll start with the diagnosis. Endoscopic examination still remains the gold standard for diagnosis of Barrett's esophagus. Two criteria must be fulfilled. The first one is an endoscopic criteria, wherein the columnar epithelium lining should be seen for a distance of more than equal to 1 centimeter of the distal esophagus, which will be seen on endoscopy as a reddish colored velvet-like mucosa as compared to a pale glossy mucosa of the squamous lining. The second criteria is a histological criteria, which is that the biopsy should show an evidence of metaplasia. Various types of metaplasia described are a cardiac metaplasia, an atrophic gastric fundic type epithelium, and specialized intestinal metaplasia. These specialized intestinal metaplasia will have columnar epithelium with goblet cells. So now most of the recent guidelines, except for the British and the Japanese one, require specifically the intestinal type metaplasia to be present as a criterion for the diagnosis of Barrett's esophagus. So for a proper assessment of the length of Barrett segment, we need to know the landmarks at the lower esophagogastric junction. So as we can see in this image, so we can see three different landmarks. One is the pinch of the diaphragmatic, which can be seen as a constriction. Another is the proximal end of the folds of the gastric mucosa, which we will consider as true esophagogastric junction for all the measurements, because many of these patients will have additionally a hiatus hernia, and we will see these landmarks will be at different points. And the third one is the squamocolumnar junction, or the Z line, wherein the red velvety mucosa merges with the pale glossy mucosa. So to classify the extent of the Barrett's esophagus, there is a Bragg's classification. So as we can see in this diagram, the pinch of the diaphragm is at 42 centimeters from upper incisors, whereas the gastroesophageal junction, that is the proximal end of gastric folds, is at 40 centimeters. So our measurements will start from here. So we can see in this image, there is a circumferential involvement of esophagus for a distance of 1 centimeter. Whereas if we measure the height of the tallest tongue or the largest tongue, it is about 36 centimeter, that is 4 centimeter away from the gastroesophageal junction. So this would be classified as Bragg's classification C1, that is circumferential 1, and M4, maximum extent of 4 centimeters. Another way of classifying Barrett's esophagus is short segments Barrett's, that is less than 3 centimeters involvement, and long segment Barrett's, that is more than 3 centimeter involvement. Once the endoscopic diagnosis is made, we need to subject it for histopathological examination. Before that, we need to take biopsies. Seattle protocol is the protocol followed for biopsy, which includes systematic assessment of the esophagus starting at the GE junction and extending up to the squamocolumnar junction. All the visible lesions suspicious for dysplasia, the targeted biopsy needs to be taken from this tissue, whereas for the macroscopically normal looking mucosa, biopsy should be taken from 4 quadrants at 2 centimeter interval throughout the length of the Barrett's esophagus. A minimum of 8 biopsies needs to be taken. The drawback of the Seattle protocol biopsy is that the average Barrett's esophageal mucosa surface area is estimated to be about 14 centimeters. With random biopsies, the amount of tissue which we gather is up to 0.5 centimeters square. That is only up to 3.5% of the entire mucosa will be studied. So there is a risk that we might miss a dysplastic tissue in between the biopsied areas. Now coming to the histopathology examination. So it is classified, the degree of dysplasia is classified based on Vienna classification. So we would classify it as non-dysplastic Barrett's esophagus, which will show only the presence of an intestinalized columnar epithelium, but there will be normal surface maturation and normal cytological features in the form of nuclear cytoplasmic ratio. There is low-grade dysplasia, which will have disruption of the surface maturation alone. Anything in between these two is an indeterminate for Barrett's esophagus, because here the surface maturation is normal, but there will be some mild cytological abnormalities. In high-grade dysplasia, along with surface maturation disruption, there is also marked cytological abnormalities. And whereas in invasive adenocarcinoma of the esophagus, there will be complete destruction of architecture and invasion of the cells into the basement membrane. So once we know how to diagnose the esophagus, what is the population in which we should do screening? So various societies at various time frame have come with various guidelines. A gist or summary of all this guidelines is the reason for screening is, the goal for screening is to decrease the mortality due to esophageal adenocarcinoma. And keeping this goal in mind, population-based mass screening does not help in reducing the mortality for esophageal adenocarcinoma. So we need to define a target population who are at high risk of developing Barrett's esophagus and progression to dysplasia, and screening in this particular group will be helpful. So the criteria required is patient should have chronic GERD symptoms for more than 5 years, or presence of frequent GERD symptoms, that is more than once weekly symptoms with nocturnal GERD symptoms. Along with this, 2, 3 or multiple of the following criteria should be present. So different guidelines have made different number of criteria to be mandatory. So male population, age more than 50 years of age, a white race or Caucasian race, presence of hiatus hernia, central obesity, use of tobacco either in the form of smoking or chewing, or history of Barrett's esophagus or esophageal adenocarcinoma in first degree relative. So all these population need to undergo screening for Barrett's esophagus. The different modalities which are available for screening include the most commonly used and the recommended one, that is high definition white light endoscopy. There are few modifications made to this in the form of transnasal endoscopy, single fiber endoscopy, and esophageal capsule endoscopy. So these 3 modalities are keeping in mind the patient's comfort and need for sedation. The other modifications are with the idea of increasing the diagnostic capacity for dysplasia. So these include virtual chromoendoscopy, a Watts 3D device, cytosponge, volumetric laser endomicroscopy, and confocal laser endomicroscopy. So as per the ASG guidelines of 2019, they have a recommendation for using chromoendoscopy and virtual chromoendoscopy in addition to white light endoscopy plus biopsy as per Seattle protocol, and it is a strong recommendation. For the use of Watts 3D, they have a conditional recommendation, and they suggest using Watts 3D in addition to white light endoscopy with Seattle protocol biopsy. Whereas for CLE, there is a suggestion against the use of CLE as a routine practice with a conditional recommendation. And for volumetric laser endomicroscopy, there is insufficient evidence to either suggest for or against the use of VLE. So this comes from a data from a very large meta-analysis which had shown that use of any form of enhanced endoscopy increases the yield. Amongst the chromoendoscopy, acetic acid therapy was use of acetic acid showed the maximum sensitivity and predictive value. Whereas amongst the image enhanced endoscopy, NBI was the one which showed maximum sensitivity and predictive value. The impact of using this was that there was an absolute increase in the dysplasia detection up to 9% and a relative increase of dysplasia detection up to 30% when this chromoendoscopies were used in addition with white light endoscopy. So coming to individual modalities, NBI, there are various criteria for NBI classification, that is Kansas, Amsterdam and Nottingham. These criteria looked for irregular mucosal pattern on NBI imaging and pattern of vasculature to predict dysplasia. So the ridged or the villus pattern was predictive for specialized intestinal metaplasia, and an irregular pattern was predictive for presence of dysplasia. They had an accuracy for non-dysplastic intestinal metaplasia between 57 to 63%, whereas for dysplasia, the accuracy was 75%. The inter-observer agreement was fair for Nottingham classification and it was moderate for Kansas and Amsterdam classification. The problem with these criteria was they came from individual centers or a group of centers and had high inter-observer variability. So there was a Barrett's International NBI group Bing consensus, and the criteria were simplified to just call it either positive, suggestive of dysplasia or not suggestive of dysplasia. So these are the criteria, where in the previous criteria, we would identify a normal mucosa, an intestinal metaplasia or a dysplasia based on NBI. Whereas now with Bings, we just look for whether there is presence of dysplasia or no dysplasia. So this Bing criteria classification use had high rate of accuracy and a negative predictive value of up to 95%. So this is the Bing criteria. So for mucosa, we look for a regular mucosa and an irregular mucosa. The regular mucosal pattern is a round, ridged or villus pattern. Here we can see a round pattern of mucosa on NBI. Whereas an irregular mucosa is anything away from this. So here we can see an irregular mucosal pattern. So this would be classified as irregular mucosal NBI on Bing classification. For vasculature, the regular vasculature is the one which follows or is in between the mucosal ridges. Anything away from this, an irregular branching pattern of vasculature will be called as an irregular vasculature. So either presence of an irregular mucosa or irregular vasculature on NBI would be diagnosed as suspicious for dysplasia based on Bing classification. Coming to the next modality, that is WATS, wide area transepithelial sampling with computer assisted analysis. When WATS 3D was added to 4-quadrant biopsy, it increased the overall detection by up to 242%, that is from 0.68% to 2.33%. This is from a very large meta-analysis of about 12,000 patients. The another study showed that absolute difference of 21 new cases diagnosed to have dysplasia when WATS 3D was added to white light endoscopy. This was about 18.6% of the cases. And based on this, the number needed to test for WATS 3D was 5, which is a good number. So a brief description of the WATS 3D technique. This is a through the endoscope device, which is a brush like the cyto brush. It has bristles which go deep into the epithelium and they abrade the entire epithelium of the mucosa. Therefore, we call it as transepithelium. This is scraped along the segment of the Barrett's along the entire circumference. So the amount of tissue and the surface area addressed to is much larger than 4-quadrant biopsy. This tissue is then processed through a central computerized artificial intelligence based technology. It undergoes 3D synthesized image of 100 optical slices. So larger amount of tissue is studied histopathologically. The tissue slides which are suspicious for dysplasia are marked by the system, and these are then verified by the histopathologist. The other modifications which we discussed were a transnasal endoscope with a smaller diameter, capsule endoscope for esophagus, and a cytosponge. These are the images from the tissue acquired through the cytosponge, whereas we can see goblet cell, and we can use immunohistochemistry with terfoil factor 3+, which will give us confirmation of the presence of goblet cells. Coming to the second part, that is treatment. The treatment is divided into chemoprevention and endoscopic treatment. Chemoprevention has a very minimal role in the treatment of Barrett's esophagus because patients who have baseline dysplasia are often treated with endoscopic ablation. And the patients who have non-dysplastic Barrett's esophagus have a very low risk of progression, and the use of medications alone does not decrease the risk of progression. So chemoprevention alone is of very less significance. Currently, it is recommended that all patients with Barrett's esophagus, regardless of the presence of GERD symptoms, should be treated with once daily PPI. Use of NSAIDs, that is, many studies have shown aspirin in the dose of 325 milligrams per day was associated with a diminished incidence of adenocarcinoma and a reduced risk of progression to adenocarcinoma in the patients with Barrett's esophagus by up to 30%. But recommendation in the form of regular use of these drugs is not advised because of the risk of bleeding and other side effects associated with NSAIDs. Endoscopic therapy. The goal of treatment in Barrett's esophagus is to eradicate the prevalent dysplasia and or cancer and to prevent the progression to invasive cancer and ultimately reduce the mortality of esophageal adenocarcinoma. So for patients with dysplastic Barrett's, the target for endoscopic therapy is to eradicate both dysplastic and non-dysplastic Barrett's metaplasia completely. Whereas for non-dysplastic Barrett's, there is paucity of evidence in favor of complete eradication or ablation. Therefore, current guidelines do not recommend eradication therapy, rather surveillance is what is recommended for non-dysplastic Barrett's. The term endoscopic eradication therapy refers to the use of the endoscopic resection or ablation or both with an idea to achieve the above goal. So the various endoscopic therapies which we have can be divided into ablative therapies and resection therapies. Amongst ablative therapy, radiofrequency ablation, cryotherapy, argon plasma coagulation, and photodynamic therapy. Resection-based strategies include endoscopic mucosal resection and endoscopic submucosal dissection. So for ablative therapies, the benefit of using ablative therapies is that extensive surface of the Barrett's esophagus can be treated with ablative therapy, whereas the drawback is no tissue is available for histopathological examination. With endoscopic mucosal resection, the benefit is that we get a full thickness biopsy which can be sent for histopathological examination to look for evidence of dysplasia, any carcinoma. If carcinoma is present, we can identify the exact depth of invasion. But the problem is, drawback is, if we do radical EMR of the entire segment, it yields very higher rates of esophageal stricture, that is up to 88%. So endoscopic ablative therapy alone cannot be used for patients who have nodular lesions. Whereas if we do endoscopic resection alone of the visible lesion and leave the remaining Barrett's metaplastic tissue for surveillance, there is very high rates of recurrent high-grade dysplasia or adenocarcinoma, that is up to 14 to 36%. So considering all this, the guidelines now recommend that for all Barrett's esophagus, there should be successful endoscopic resection of all the visible abnormalities, and an endoscopic ablative therapy should be used for the residual component of the Barrett's esophagus to achieve complete eradication of intestinal metaplasia. And the use of this combination therapy has shown to eradicate high-grade dysplasia in 86 to 92% of the cases and intestinal metaplasia in 62 to 87% of the cases. Coming to radiofrequency ablation involves use of thermal injury to the superficial 0.5 millimeters of the esophageal mucosa, resulting in tissue necrosis, which eventually gets sloughed off and is taken over by a growth of neosquamous mucosa. It can be applied either in a circumferential or a focal fashion. The most common adverse effects are stricture formation, pain, and bleeding. It is the ablative procedure of choice for dysplasia as per various guidelines because of the enormous amount of data in various trials which is available for its efficacy and safety. The endoscopic mucosal resection. In this, a diathermic snare similar to that of a polypectomy snare is used to resect a segment of esophageal mucosa and the underlying submucosa, which is submitted for pathological evaluation. The different techniques we have are suck and cut technique and band and snare technique. In suck and cut technique, the mucosa is sucked through the cap to create a pseudopolyp and it is then snared off. In band and snare technique, we use a device similar to the endoscopic variceal ligation device, and the nodular Barrett's mucosa is sucked and banded over, and then it is snared over the applied band. In a head-to-head comparison, band ligation was found to be less costly, more time effective, and with fewer adverse events. So endoscopic mucosal resection is a therapy to remove neoplastic mucosa, and also it is the most accurate means available to delineate the depth of invasion. So thus it helps in both the diagnosis and treatment. So these are the images of a radial balloon radiofrequency ablation device, whereas this one is a focal radiofrequency ablation where we can use it for focal ablative therapy. This is an image of a suspected dysplasia in the Barrett's esophagus mucosa. This is the suck and cut method, band and snare method, wherein we use this band device to band the tissue and then snare. After snaring, we can see this submucosa, which can be seen below the resected mucosa. So before going ahead with the endoscopic therapy, a few things must be kept in mind. One is the histopathological diagnosis of any dysplasia, either low grade or high grade, should be confirmed by an expert, experienced gastrointestinal pathologist. Only after two pathologists certify it to be a dysplasia, we should go ahead with endoscopic therapy, considering it as a dysplastic Barrett's esophagus. The patient should be educated about the possible complications in the form of stricture formation, bleeding, or perforation. They should also be educated for the need of multiple endoscopies for the treatment as well as the surveillance thereafter. There is a caveat in low-grade dysplasia. Few guidelines now suggest to go ahead directly with eradication therapy, but few still suggest a repeat endoscopy within 3 to 6 months while the patient is on optimal acid suppression to evaluate for the persistence of low-grade dysplasia or any development of advanced neoplasia, and based on that decide on the endoscopic eradication therapy. So this is a table which will more or less summarize which therapy to be used in what type of Barrett's esophagus. So based on endoscopy and histopathology biopsy samples, we would classify Barrett's esophagus. If it is a non-dysplastic Barrett's esophagus, surveillance endoscopy every 3 to 5 years is advised. If it is indefinite for dysplasia, a repeat endoscopy should be done within 3 to 6 months with maximum acid suppressive therapy. After this 3 to 6 months, if the repeat biopsy is also suspicious of indefinite for dysplasia, a repeat endoscopy is advised after 1 year and annually thereafter. If it is negative, if it shows presence of any dysplasia, then depending on the severity of the dysplasia, the further course should be taken. For low-grade dysplasia and high-grade dysplasia both, if there is any visible lesion on OGDscopy, that lesion should be subjected to EMR and sent for histopathological examination, whereas for non-visible lesions, the patient should be subjected for endoscopic ablation therapy. And after the histopathological examination, if the tissue shows risk of low risk for an invasive carcinoma, that is a submucosal infiltration of less than 500 micrometers, good or a moderate differentiation type of carcinoma without any lymphovascular invasion and a tumor-free deep margin. So for all these patients, endoscopic ablative therapy should be done for the remaining macroscopically normal-looking Barrett's esophagus. Whereas if the patient has a submucosal adenocarcinoma, decision of ESD versus surgery should be considered with a multidisciplinary approach, and the treatment should be decided accordingly. So defining the endpoints of endoscopic eradication therapy, it should be continued until there is an absence of columnar epithelium in the tubular esophagus or on high definition white light endoscopy, and preferably with the use of an optical chromoendoscopy. Neosquamous mucosa of the entire length of the previously prevalent Barrett segment should be biopsied. Along with that, biopsies should also be taken from the gastric cardia in the 4th quadrant, because this is the area which will most prone to develop metaplasia after a successful therapy. Presence of any intestinal metaplasia, dysplasia, or a subsquamous columnar epithelium, visible island, or tongues should all undergo targeted focal ablative therapy. Surveillance post the eradication of the Barrett's esophagus therapy. This will depend on what was the baseline classification or the severity. If the baseline diagnosis was high-grade dysplasia or esophageal adenocarcinoma, surveillance to be done at 3 months, 6 months, and 12 months, and then annually thereafter. If the baseline diagnosis was low-grade dysplasia, surveillance at 1 year and 3 years. In case any recurrence is found,
you have to wind up.
Yes, sir. Just last one slide, sir. So any recurrence should be treated as the previous one. Coming to some Indian data, few Indian data is available on the prevalence of Barrett's esophagus. This is specifically when the patients with GERD are subjected to endoscopy, up to 6%, 9%, and 2.38% in various studies from various areas, Western India and Northern India. Just a summary for the entire presentation. Screening, patients with chronic GERD with risk factors should undergo screening. For surveillance, white light endoscopy along with chromoendoscopy. For non-dysplastic Barrett's, surveillance alone. For dysplastic Barrett's, endoscopic eradication in the form of resection of nodular lesions and ablation of the remaining segment of Barrett's esophagus. Thank you.
Before Dr. Ubal and the team takes over, I must congratulate you. This is one of the good presentations I have seen. I think that you had the right amount of material on the slides and you spoke exactly what is required. So I must compliment your presentation.
Thank you.
With that, I'll pass to Dr. Ubal. I do have a couple of questions, but we are running short of time. So we'll allow only about 5 minutes and then we'll move on to the second question. Dr. Ubal. So have we lost Dr. Ubal, Dr. Preeti? Any one of you are there?
We are there, sir.
Yeah. So there are a couple of questions which are on the chat box. One is that when you talk about short segment versus long segment, are you talking of maximum length or you're talking of circumferential length?
So it is the maximum length, including both circumferential as well as the tongues.
You did answer the other question about Barrett's in India, so I think we need not take that question.
That's a question, Pavin. We do not see many patients with the classic Barrett's in India. And in some classical CM classification, it is not possible. Please throw some light on it.
Sir, but the data which has shown shows that if we consider the prevalence and incidence of Barrett's esophagus in the patients who have GERD symptoms as per the screening criteria, the prevalence is varying up to from 2.5 to up to 20% in some studies from the Indian data.
So I have a couple of questions. When you're showing the radiofrequency ablation pictures, you showed three. There was three pictures. You did not tell us about the third one. What is the third image which was there? One is circumferential, one you said focal, and there was one more image. Can you clarify on that?
The third one was the one which we can use through the scope, sir. It is also for focal ablation.
That's the latest addition in the RFA technique. That the first one is quite complicated. That you have to first do the sizing of the balloon. So you have to find out which size of balloon you're going to use. Whereas the second and third are less complicated, but again, you have a chance of losing, not handling some of the areas. What do we do about low-grade dysplasia? Is there any data on RFA being done for low-grade dysplasias?
Sir, the latest AGA guidelines for endoscopic therapy, they have shown, sir, that comparative data for low-grade dysplasia with ablation and without ablation, sir, it is advisable to go ahead for ablative therapy, sir. Long-term follow-up of 84 months data which they have shown us that with ablative therapy, the risk of progression to adenocarcinoma is reduced.
So what about non-dysplastic Barrett's? Only metaplasia. Is there any role for doing RFA in non-dysplastic cases?
The data is still not clear, sir. Few studies suggest in favor of doing ablation, but the other studies say that surveillance alone is sufficient enough.
One more question that you talked about Seattle protocol. Seattle protocol is with white light.
Yes,
what
sir.
if you are using NBI or any of these enhanced imaging? Do you still need to follow the Seattle protocol, or you think that you'll only pick up biopsies from the abnormal areas?
Sir, technically, if we are using an image-enhanced endoscopy, sir, we should be taking biopsies only from the suspected areas. But whatever studies have been done, they are using white light endoscopy with Seattle protocol, and in addition to that, they have used a new modality. So either a virtual chromoendoscopy or anything has been used in addition to Seattle protocol and white light endoscopy, sir. So we should still be taking biopsies as per.
Anyone of you have any questions? Anyone of the faculty has any questions or comments?
Nothing, sir. Nothing from our side, sir.
Dr. Preeti?
Nothing, sir.
All right. So I think you did not talk about hybrid APC. You did mention in passing about APC being used as an ablative therapy.
Yes, sir.
Are you aware of some modification of the APC which has been used for Barrett's?
No, sir.
So there is a hybrid APC where you inject before you do ablation. So you first inject in the base and then you ablate with the APC. and it has been found to be comparative to the RFA technique. Unfortunately, we did a few RFAs about 5 or 7 years back in Barrett's esophagus and other indications. But at this moment, though we have the RFA machine in about 3 or 4 centers in India, but somehow these accessories are not available because there is a change of the companies. Now it's with Medtronics, and Medtronics is not interested in selling it in India because of the low requirement, because of the perception of Barrett's being low. So we are stuck with a white elephant that we all have the machine, but we do not have the accessories. Anyway, that was in passing. So if there are no more comments, can we pass on to the second presentation, Dr. Upal?
Over the second presentation. That is an interesting case of jaundice that will be presented by Dr. Vivek.
I thought this doctor was Vivek because the name is coming as Vivek.
No,
sir.
This is Bhavin.
Okay, all right.
Who presented is Bhavin.
Good evening, faculty members and all my colleagues. I am Dr. Vivek, third year DNB Registrar, Medical Gastroenterology from Apollo Hospital, Chennai. I will be presenting an interesting case of jaundice and its consequences. This is a 52-year-old male, married businessman from Chennai, with a complaint of abdomen pain, yellowish discoloration of eyes, and dark color urine since last 2 days. History of presenting illness: the patient had abdomen pain for 2 days, which was localized in the right upper quadrant, insidious in onset, dull aching, moderate intensity, continuous, non-radiating, no aggravating or relieving factor was there, was associated with nausea and vomiting. Patient has had 2 episodes of vomiting, postprandial containing food undigested, non-bilious, non-blood stained, 1 day before the admission. Patient also had a yellowish discoloration of eyes and change in the color of urine. Since 2 days, it was not associated with itching, no history of pale color stool or fever. Patient also complained of decreased appetite since last 4 days, but there was no associated weight loss. There was no history of rash, joint pain, jaundice in the past, abdomen distension, decreased urine output, black color stools, blood in vomiting or altered sensorium. There is no history of IV drug abuse, high-risk sexual behavior or tattoo marks. In the past history, patient has a known case of diabetes mellitus and hypertension since last 20 years. A known case of ischemic heart disease post-CABG status 20 years back. Patient required 3 units of blood transfusion at the time of surgery. Patient is a non-smoker, non-alcoholic. Medication history: there is a history of ingestion of amoxicillin clavulanate for 5 days for dry cough. Patient has stopped the medication 2 days back. Patient also gives history of complementary alternative medication in the form of herbal medication, which the patient has taken for 1 month, which was stopped 1 week back just before starting augmentin and clavulanate. On further investigation, it was found that the herbal preparation was a dry herbal formulation containing ashwagandha, guduchi, and tulsi. Other than this, the patient was also on his regular medication, which included beta blocker, that is metoprolol, ACE inhibitors, antiplatelet, statin, that is atorvastatin, and antidiabetic medication, that is glyphosate GP1, which contained metformin and glimepiride. So this is the timeline of events. Patient has taken 1 month of complementary alternative medication. Patient developed some cough at the end of it, which was a dry type of cough. Patient has taken amoxicillin clavulanate for 5 days. By the 3rd day of amoxicillin clavulanate itself, the patient started having decreased anorexia with sensation of nausea. By the end of the course of amoxicillin clavulanate, patient developed jaundice and presented to the hospital. On examination, patient was afebrile with a pulse rate of 100 per minute and a blood pressure of 150 by 90 millimeter of mercury. Pictures was present, no pallor, clubbing or pedal edema, no peripheral signs of chronic liver disease. On per abdomen examination, it was soft, non-tender, no hepatosplenomegaly, no flank fullness, normal bowel sounds. Per rectal examination, normal yellow color stools. Other system examination were normal. So the summary of the case is a 52-year-old male, known case of diabetes, mellitus, hypertension, ischemic heart disease post-CABG status, presenting with a history of jaundice and abdomen pain, vomiting, nausea, and decreased appetite following complementary alternative medicine intake. Performance status 0 by 5. A syndromic diagnosis of acute hepatitis with no features of liver failure. So the differential diagnosis we considered at the end of history and examination was drug-induced liver injury because of the significant temporal association which was there. Other differentials which we considered was acute viral hepatitis, reactivation of chronic viral hepatitis, autoimmune hepatitis, and biliary obstruction, extrahepatic biliary obstruction. So these were the investigations the patient has already done before getting admitted to the hospital 1 day before admission, which showed in which the CBC showed thrombocytosis and a direct hyperbilirubinemia. The total bilirubin was 7.7 with a direct component of 6.1. Significantly elevated enzymes SGOT and SGPT more than 10 times elevated. ALP, which was 2,216, which was again more than 10 times elevated. Albumin was 4.5 and no synthetic dysfunction. The INR was 1.1. Because of the abdomen pain, patient has already underwent ultrasound abdomen before getting admitted, which showed a 8 into 5 millimeter calculus in the neck of the gallbladder. No gallbladder wall thickness, no pericholecystic fluid, no intrahepatic biliary radical dilatation. In order to rule out Meniere's syndrome or any other cause of microlithiasis, MRCP was done, which showed cholelithiasis with minimal gallbladder wall thickening, no pericholecystic free fluid, mild hepatomegaly with periportal cuffing, no biliary tract filling defects, no intrahepatic biliary radical dilatation. Further etiological workup was done in the form of viral markers and autoimmune workup. In the viral markers, chronic viral infections, HBsAg and anti-HCV was negative. For acute viral infection, hepatitis A and E was done, which was negative. Anti-HBC IgM was negative. Autoimmune workup included ANA, ANCA, asthma, and AMA, all of which was negative. Serum total IgG was negative in the normal range. Liver IgG profile was done, which included LC1, LKM1, SLA, and M2 PDH, all of which was negative. So the patient was admitted, started on supportive treatment. Already the complementary alternative medication that the patient was taking, the patient has already stopped. Because of the cholestatic pattern in the liver function test, we have started the patient on ursodeoxycholic acid. And this was the outside blood investigation which was done. And this is the follow-up serial repeat LFTs which has been done during the stay of the hospital. The bilirubin showed a significant improvement in the initial few days, which later on stabilized. SGOT, PT were decreased by almost more than 50%. ALP, GGTP more or less remains constant throughout the duration of the stay in the hospital. Synthetic function in the form of INR remained normal. Patient improved clinically, appetite improved. Patient was doing well, and patient was symptomatic in view of improving transaminase level. Patient was discharged on 14/10/2020 with a provisional diagnosis of drug-induced liver injury with moderate severity. Patient was advised to follow up with a repeat liver function test after 1 week. So this is from the liver toxic NCBI bookshelf. Drug-induced liver injury caused by amoxicillin clavulanic acid. This is one of the most common antibiotic-induced liver injury. Onset of injury is typically a few days to as long as 8 weeks. General presentation is in the form of fatigue, low-grade fever, nausea, and abdomen pain, which is followed by pruritus and jaundice, which did not fit into our temporal association in our patient. The patient generally will have a typically cholestatic type of liver injury with marked elevation of ALP and GGTP. Patient will have a prolonged course of jaundice lasting for 4 to 24 weeks. The other case report which we came across as an original article on ashwagandha-induced liver injury, a case series from Icelandic and US drug-induced liver injury network. Till date, only 5 cases have been reported, out of which 3 were male. Mean age was 43. Presenting complaint was in the form of jaundice, nausea, lethargy, pruritus, and abdomen pain. The latency period of 2 to 12 weeks. None of these patients developed liver failure. LFTs mainly showed a cholestatic or a mixed type of injury. There was a prolonged hyperbilirubinemia, and LFT took 1 to 5 months to normalize. Out of these 5 patients, only 1 patient underwent liver biopsy, which showed acute cholestatic hepatitis with mild to moderate inflammation and canalicular cholestasis. Severity was moderate in all these cases. So this fitted better with our patient's presentation. So severity-wise, they have divided drug-induced liver injury into mild, moderate, and severe. Mild includes serum enzyme elevation reaching a criteria for drug-induced liver injury, but a bilirubin of less than 2.5. Moderate, in which the bilirubin will be more than 2.5, or there will be symptomatic hepatitis. And severe cases will have a bilirubin of more than 2.5 and signs of liver failure in the form of deranged coagulopathy, INR of more than 1.5, ascites and or encephalopathy, or other organ dysfunction, which could be related to drug-induced liver injury or fatal, with death or liver transplantation due to drug-induced liver injury within 6 months of onset. So now this patient came back after 1 week on the OPD follow-up. There was some diffuse abdomen pain, which he was complaining since last 2 days, which was continuous in nature, mild to moderate in intensity, non-spasmodic, not associated with any nausea, vomiting, abdomen bloating, or constipation. No aggravating or relieving factor. He was also complaining of dysuria since last 2 days, but there was no history of fever, blood in urine, or back pain. Patient got readmitted for further evaluation. On physical examination, patient was afebrile, hemodynamically stable, icterus was persistently there. Per abdomen examination was soft, non-tender, no hepatosplenomegaly, moderate normal bowel sounds. Other system examination was normal. So this is the investigation at the time of discharge and at the time of readmission. CBC remained more or less the same. There was a significant elevation in the bilirubin, which almost doubled over a period of 1 week. Otherwise, enzymes and SGOT, SGPT, ALP, GGTP remained more or less the same. INR also, there was no worsening of the INR. A repeat ultrasound was done, which showed grade 1 fatty liver. Gallbladder was minimally distended with a wall thickness of 4 mm. Urinary bladder showed distension with wall thickness of 4 mm with significant post-void residue of approximately 150 ml. On the very next day of admission, patient developed altered sensorium and was shifted to ICU. Serum ammonia was done, which was within normal range. Patient developed hyponatremia, sodium of 99. The discharge sodium 1 week back was 133. Patient was also found to have hypercholesterolemia with a cholesterol of 1029, HDL of less than 5, LDL of 980 milligram per deciliter, whereas the triglycerides was within normal limits. A multidisciplinary consult was done, and patient was further evaluated for hyponatremia and hypercholesterolemia. For the evaluation of hyponatremia, serum osmolarity was done, which was 277, which was low, which was suggestive of true hyponatremia. Simultaneously, there was elevation of urine spot sodium, which was more than 20, and urine osmolarity, which was 301, which was high. All this was suggestive of acute symptomatic hyponatremia with in a euvolemic patient, likely due to SIADH related with a component of pseudohyponatremia because of hypercholesterolemia. Patient was started on treatment with IV 3% NaCl, fluid restriction, high salt diet, and tolvaptan. Over the stay in the ICU in the next 3 to 4 days, the sodium improved, the sensorium improved, and the patient after 4 days was shifted back to ward. By the time the patient was shifted back to ward, the sodium was already 130, and within the first 2 days itself, the sensorium of the patient significantly improved. Simultaneously, evaluation was also done for hypercholesterolemia to differentiate between familial hypercholesterolemia versus cholestatic jaundice related hypercholesterolemia. Apolipoprotein B levels was done, which was 121, which was within the normal range. In cases of familial hypercholesterolemia, apolipoprotein B levels will be on the lower side, whereas in cases of true hypercholesterolemia, the apolipoprotein levels will increase parallel to the LDL levels, so which was not fitting into this because the apolipoprotein was normal. So this was because due to an abnormal lipoprotein which was present, which was not detected on routine test. Lipoprotein electrophoresis was done following, which showed an elevated pre-beta lipoprotein levels, which was suggestive of VLDL elevation. Patient was continued on statin. This is the on-admission cholesterol level and lipid profile, whereas this is the lipid profile which was done on 28. There was no significant improvement, rather there was some slight worsening of the cholesterol. In consultation with the nephrologist, cardiologist, endocrinologist, patient was planned for LDL pheresis. Patient underwent 3 cycles of LDL pheresis on 29th, 31st, and 2nd. This was the pre and post LDL pheresis reports of the cholesterol. Cholesterol showed a significant improvement after LDL pheresis, which came back to almost less than 300 by 511, which was within the normal range. Simultaneously, the LDL level, which was also significantly elevated, came down to normal limits. Whereas the rest of the liver function test After the initial first cycle of plasmapheresis, there was some improvement in the bilirubin, after which it remained more or less the same. There was some improvement in SGOT, SGPT, and the ALP GGTP more or less remained constant. Albumin, there was initial drop, followed by there was a pickup in the serum albumin level. INR was never deranged. Patient never developed elevated serum ammonia, or there was never an evidence of ascites. Serum sodium also improved significantly, and patient was discharged. Before discharge, we have also done a liver biopsy for this patient, which showed a disrupted spatial relationship between the portal tract due to portal tract expansion and focal evidence of confluent hepatocyte dropout and necrosis, which contained mixed lymphocyte, few neutrophils and eosinophils. There was bile duct injury with cytoplasmic vacuolation and eosinophilia and loss of nuclear polarity. Also, there was parenchymal changes in zone 3 hepatocellular and canalicular cholestasis with mild sinusoidal dilatation was seen. The trichome stain was used, which showed fibrosis. Iron stain, no evidence of iron store, excess iron store was there. Copper stain was negative for periportal copper deposits, and reticular stain showed hepatocyte rosetting, which was suggestive of regeneration. These were the biopsy. This is the portal tract expansion with significant inflammatory cells seen around it. The inflammatory cells included plasma cells, lymphocytes, eosinophils, along with few neutrophils. The ductular reaction was seen. A proliferation of the bile duct was seen, with vacuolation of the cytoplasm was also seen because of the bile duct injury. The significant cholestasis in the zone 3 area, this brown pigmentation denotes the cholestasis in the zone 3 area and in the canaliculi. There were sheets of foamy histiocyte aggregates which was seen. Periportal edema with ductular reaction and hepatocyte fallout was seen. Hepatocyte ballooning was seen. And hepatocyte fallout, which was significantly demonstrated in the zone 3 area. So the conclusion was a predominant zone 3 hepatocanalicular cholestasis with focal hepatocyte necrosis, portal tract edema with interlobular bile duct injury associated with ductular reaction and focal ductular cholestasis, atypical combination of parenchymal cholestasis and focal hepatocyte necrosis and bile duct injury, most likely drug-induced liver injury related. The course in hospital patient improved clinically with LDL pheresis and correction of hyponatremia. Was discharged on 9/11/2020 with a diagnosis of drug-induced liver injury complicated by hypercholesterolemia, likely due to lipoprotein-X, and symptomatic hyponatremia, which was SIADH related, plus a component of pseudohyponatremia, which could not be ruled out. On follow-up, the patient followed up every 15th day. The patient followed up. In the first 15-day follow-up itself, the bilirubin was showing a significant improvement, with significant improvement in the SGOT as well as the ALP and GGTP. By 1.5 month follow-up, almost the rest of the LFT, everything has improved, including the albumin, and INR remains the same. This was during the first follow-up, the cholesterol levels were repeated, which did not show further increase. The unique feature in this case included drug-induced liver injury, whether related to amoxicillin clavulinate or CAM-induced. The temporal association favors more in favor of CAM. There was an altered sensorium in presence of liver injury, not due to liver failure, but due to hyponatremia related. Hyponatremia was due to hypercholesterolemia and SIADH related, and significant hypercholesterolemia due to cholestatic jaundice. The management was done with LDL pheresis. Hypercholesterolemia with jaundice. This is 2013 case report from American Journal of Gastroenterology. This is a case of extrahepatic biliary obstruction because of neurofibromatosis type 1. This patient presented with a bilirubin of 18.6 and a total cholesterol of more than 1000. Underwent ERCP with a CBD, proximal CBD stricture, and sense placement was done. After which, within a period of 2 to 3 weeks, the total bilirubin came down to 2 with a significant improvement in the total cholesterol as well as the LDL level. A similar case report has also been reported in 2017. Again, this is an extrahepatic biliary obstruction due to gallstone related. In this patient also, ERCP and stenting was done, which showed us following which there was a significant improvement in the cholestasis, that is the bilirubin, as well as a significant improvement in the cholesterol levels. This is a case of intrahepatic cholestasis. This is a case report from 2019 from SAGE. 28-year-old female with a known case of primary biliary cirrhosis. She has stopped her medications and she presented with significant elevation of alkaline phosphate of 1777 with a total bilirubin of 9.6 and a direct component of 5.6. At this point of time, the total cholesterol was 1535. So this patient was treated with UDCA and fenofibrate. In a period of 3 to 4 months, there was a significant improvement in the liver function along with an improvement in the cholesterol levels. So what is Lipoprotein-X? Lipoprotein-X is a low density
You have
lipoprotein.
only 2 more minutes.
Yes, sir, I'm about to finish, yes, sir. It contains lipoprotein, phospholipids of 66%, unesterified cholesterol 22%, and very lipid triglyceride, cholesterol esters, and protein content of about 6%. On electrophoretic mobility, the density is somewhat equal to VLDL and LDL. This is basically the refluxed lipids which cannot be excreted through the bile. So this comes into the blood circulation and combines with albumin. This protein, lipoprotein, lacks ApoB. So because of this lack of apoprotein B, it cannot be metabolized and taken up by the liver because of the lack of receptor. Simultaneously, because of the large size, it cannot be excreted through the kidneys. This protein will be eventually metabolized by the spleen, by macrophages, and it takes a lot of time for that. Also, because of the absence of apolipoprotein B, it is unable to exert a negative feedback effect on the synthesis of HMG CoA reductase. Rather, it increases the activity of HMG CoA reductase in liver, and it increases the further production of hepatic cholesterol synthesis. The complication associated with which have been reported have been xanthoma, retinal cholesterol deposition, thromboembolism, cholesterol of the lung, and hyperviscosity syndrome. Pseudohyponatremia have also been reported in cases of increased lipoprotein-X. Treatment statin won't work in these cases because apoprotein receptor is absent on the surface of these molecules. Ezetimibe, which inhibits the absorption of dietary cholesterol, will also not help because it is basically a refluxed lipoprotein from the liver cells. Fenofibrates also have no efficacy. LDL pheresis have been shown to have improvement, especially in cases who have hyperviscosity syndrome, pulmonary embolism, and other form of complication like cholesterolomas in the lungs. So the literature, there have been no case of ashwagandha-related drug injury, drug-induced liver injury, which have been reported from India. Our patient had clinical and biochemical pictures similar to other cases which have been described in the literature. Drug-induced liver injury-related lipoprotein-X, only one case report have been described in the literature. Thank you.
Thank you, Dr. Singh. Any comments from Dr. Ubbal, Dr. Seshadri, or Dr. Preeti?
So, thanks, Vivek. Nicely presented. I think this
Thank
case was presented because of the rarity of drug-induced liver disease, because we use normally a lot of the coronal in the Indian population. So this presented mainly for the rarity and also the associated complication due to cholestatic jaundice, mainly in the form of hyponatremia and hypercholesterolemia, and the management of these conditions. Vivek, there are some questions in the question box, and how the patient improved after LDL pheresis?
The patient did not improve from the LFT point of view. The patient improved. LDL pheresis only was done for the hypercholesterolemia. It did not improve the liver function. Liver function took its own time to improve, and it was not related to the LDL pheresis was not done for the liver dysfunction, sir. It was done only for hypercholesterolemia. Patient improved with the correction of hyponatremia, sir.
And the other
Can you
question,
describe the technique of
what-
LDL pheresis? How is LDL pheresis done? What is the volume and all?
Yes, sir. So LDL, the difference between plasma exchange and LDL pheresis is in plasma exchange, we will separate the cellular component in the plasma. The plasma that is collected will be discarded and replacement fluid will be given instead of plasma. Whereas in cases of LDL pheresis, the same plasma which has been separated will go through a filter. There is a specialized filter to remove the LDL component. So only that LDL will be removed and the rest of the plasma will go back into the circulation again, sir. It is just a filtration, sir, rather than exchange.
So how do you filter it? Is there special filters for this?
Special filters are available, sir. Yes, sir, for LDL pheresis, sir.
Okay.
So actually, this has been
Yes.
A lot of cases of this thing has been reported, sir, from hematopoietic stem cell transplant. After doing that, sir, because of the immunosuppression and graft versus host disease, the development of cholestatic jaundice in these patients, they require very frequently LDL pheresis for elevated hypercholesterolemia, sir. So a case series of 7 cases have been reported, sir, in the single center.
Dr. Ubal, we have seen at least half a dozen of Giloy-related hepatotoxicity, where the specific substance was Giloy. And I think Giloy has been commonly used with a thought process of preventing COVID. So what's the experience? Do you have a similar experience in Chennai?
So this patient who was taking a combination, sir. So Giloy cases have been reported, sir.
I had a patient, sir, 72-year-old with Giloy poisoning, presenting almost like an ALF. She died within 2 days of presentation, with history of intake of Giloy for almost 2 months. But the temporal period was quite long, actually. Almost 4 to 5 months since she stopped the drug. But the patient died within 2 months
We
of
have
2 days of
as I
admission.
said, about 6 to 7
Presented with
cases, and we
pulmonary
also lost 2 of them.
liver
And
failure
we
kind
could
of thing.
not-
And also
we
very
could not
interestingly, she had
find anything.
thrombocytosis. Thrombocytosis of 10 lakhs plus.
Mhm. Okay. All right. So good cases. I think we have already crossed our time. So if there are any final comments from Dr. Seshadri, Dr. Preeti, or Dr. Ubal before we close.
Thank you, sir. I think thanks for the opportunity, and maybe we